the question you have to ask is, why have a webinar on the management of the arterial duct in premature babies? I think it began about 2 years ago when we offered transcatheter arterial duct closure for the premature infant at the hospital for sick children. And what became apparent to us very quickly as we embarked on this program was that despite several studies and numerous publications on the topic, the decision of when to treat and how to treat the ductus in this setting was a topic of debate within the neonatology community. Now, this is just an example of a PubMed search that I did yesterday, typing in PDA closure in premature babies. And you can see there's 525 publications since 1971, but actually almost half of them have occurred in the last 5 years. So we thought that it would be worthwhile to share our experiences in the program development at a time when transcatheter management was just beginning to become a viable treatment modality, focusing on several topics. One, the current understanding of the indications for the intervention or an intervention, the framework to develop a program across subspecialties and across institutions, because many of our referrals come from off the campus at the hospital for sick children. Then we wanted to discuss the bare bones of the transcatheter procedure. And finally, does it actually help the child? What does the data have to say? So the program tonight will cover many of those topics. The first speaker is Dr. Danny Wise, a neonatologist at Sunnybrook, will discuss the indications for intervention, why transcatheter. Lynn Lee, who was instrumental in helping us put the program together at Sick Kids, will talk about the challenges and obstacles in developing a program for ductal closure. Vanessa Chen, a cardiac anesthesiologist, will discuss the anesthetic management in the catheter laboratory. Connell Morgan, staff echocardiographer, the role of cardiac echo in the diagnosis, during the intervention, and following the intervention in the follow-up. Rajiv Chaturvedi, staff interventional cardiologist, on the implantation procedure itself. And then finally, Bani Jazani, one of the neonatologists at Sick Kids, on the outcomes, both discussing catheter-based and surgical. So with that, I think we start with Danny's presentation.
Thank you very much, Lee, for the kind introduction and for the opportunity to present today on indications for intervention, why transcatheter device closure. I have no disclosures to resolve. And although the title of this talk, Indications for Intervention, it seems rather simple, I think any clinician involved in the management of PDA in preterm infants will attest that for decades, any topic on the management of PDA has neither been simple nor straightforward. This is the PDA management conundrum that we have in the year 2021. And as a starting point, it's worth mentioning that in contemporary practice, the babies who are considered for transcatheter closure or any type of definitive closure are generally extremely preterm neonates who have a persistent PDA despite unsuccessful or contraindicated pharmacotherapy. And clinicians who have a baby like this, they have several decisions to make. The first is whether or not to attempt definitive ductal closure, whether in the form of PDA ligation or transcatheter device closure, or to attempt a trial of conservative management. And while the definition of conservative management is pretty amorphous, at the moment it generally involves using intensive care strategies such as diuretics, for example, or increased positive pressure, to allow a baby to tolerate the ductal shunt without actually facilitating ductal closure. And it's usually used in conjunct with other treatments to facilitate weaning from respiratory support. Now, amongst those babies who clinicians initially adopt a conservative management approach when the baby has a persistent large PDA despite medical treatment, At some point, some clinicians get frustrated that baby's progress has not gotten better, often in terms of weaning of respiratory support. And although they hoped for initial spontaneous closure, and they're monitoring for close monitoring for complications of a chronic left to right shunt, some clinicians eventually get frustrated that things aren't improving. The PDA is still there and large, and they abandon conservative management and end up going for some type of definitive closure. So in terms of the indications for intervention, there are actually three questions, three indications, and we'll try and work through those over the next 10 minutes or so. And the first, as you can see here, is amongst clinicians who have committed their baby to some type of definitive closure. How do they choose between surgical ligation and transcatheter based device closure? And Dr. Jasani is going to be looking at this in more detail, and we'll touch on this very briefly. The second question, and moving a bit higher up in our flow chart here, is amongst the clinicians who have a baby with persistent large PDA despite medical therapy, how do clinicians choose between a definitive closure right away, just sending them off to either ligation or transcatheter closure, versus a trial of conservative management? So we'll look at how to decide that this important question. And finally, for clinicians who have initially decided on conservative management, but they don't feel it's working, when to abandon it and move on to definitive closure. As you can see from this graph, clinicians have been abandoning PDA ligation in droves over the last 10 to 15 years. And this is the ligation rate among preterm infants with PDA in 4 large North American networks. You may see this slide or a comparable slide in several of the presentations today. But suffice to say that over a 10-year period, and this trend has continued, neonatologists are increasingly less likely to refer a baby with a persistent PDA for surgical ligation. Part of it may be because of a perception of harm, and there's no shortage of complications that have been associated with surgical ligation, as you can see here, and they tend to involve a surgical approach. And that's typically a posterior lateral thoracotomy, a pleural incision with lung retraction and exploration, as well as the application of a clip or ligature to the ductus. And starting about 2005, there were a number of publications that associated some of these complications and PDA ligation itself with adverse outcomes, things specifically related to ligation like vocal cord paralysis and in some cases post-ligation cardiac syndrome, and other things like chylothorax and pneumothorax. And in a meta-analysis of observational studies published several years ago now, compared with babies who are medically managed only, those who were treated with ligation had significantly increased odds of major neonatal morbidities like BPD and ROP, as well as significantly increased neurodevelopmental impairment in childhood. So clinicians may have digested all of that data and kind of come up with the following potential pathway, where they know that PDA ligation is associated with certain surgical complications, things like post-ligation cardiac syndrome, vocal cord paresis, pneumothorax, chylothorax. And these in the literature have been associated with increase in BPD and ROP, and those in turn linked to increased neurodevelopmental impairment in early childhood. And this suggested pathway has attributed harm to surgical ligation in the minds and hearts of many neonatologists and potentially cardiologists. This may explain why clinicians have been increasingly reticent to send babies for ligation. On the flip side, with the introduction and availability of transcatheter device closure, clinicians have been somewhat excited because some of the complications that they are aware of in that pathway of morbidity do not occur with transcatheter device closure. Things like vocal cord paresis, pneumothorax, and chylothorax are much less likely to occur because of the surgical approach. And among centers that have introduced transcatheter device closure or percutaneous closure, you can see, and as is the case here in Nationwide Children's in Ohio, that they have essentially abandoned surgical ligation entirely. And you can see that in 2014, in this particular center, as transcatheter device closure became more and more common, surgical ligation essentially went to zero. So although there are no clinical trials that have done a head-to-head comparison of ligation versus transcatheter device closure, clinicians have the perception, for various reasons, whether it's true or not is a matter of debate perhaps, but that transcatheter closure, if you're a clinician seeking definitive closure, there's a perception that it may be safer because of the approach. And that will be discussed, I'm sure, in further detail later. So in terms of our second question, if you are a clinician, you have an extremely preterm baby with a persistent PDA despite medical therapy, how do you decide whether to actually send the baby for definitive closure or attempt the trial of conservative management? And what clinicians are doing when considering conservative management is essentially hoping for spontaneous closure. They can just wait this out. And that data comes from studies such as this, which purport to be natural history studies of the PDA. And you can see Yana Semberova's study published a few years back in Pediatrics. She took a cohort of several hundred babies and looked at the time to PDA closure and stratified according to birth weight. And here, even amongst the smallest babies, birth weights of under 750 grams or under 1,000 grams, almost all babies experienced spontaneous ductal closure prior to discharge. Now, there were still about 20 to 30% of babies where the PDA was still patent at discharge, but a lot of clinicians have used this as fodder to say, well, maybe we should just wait. There's no sense in applying an intervention when the natural history of a disease is towards spontaneous resolution. And of course, there are limitations to such studies, of which there are now a number, including the fact that none of them had a control group, that many of the studies excluded infants who died, and death is, of course, a competing event for ductal closure. And the final premise when you're discussing something like transcatheter device closure, that definitive closure is intended to be a highly selective procedure, that it's not supposed to be applied to a broad population. And so population-based studies such as this may not be easily applicable to our question of who to send for transcatheter closure. And there's now an increasing number of studies that have shown some of the perils of a one-size-fits-all approach to just managing all babies with a persistent PDA conservatively. And this is data that has just been published from a tertiary center in Montreal. And in this particular site in 2014, I'll draw your attention to the solid green line, which is the rate of death or BPD as a proportion of the population. In 2014, this center changed from rather aggressive pharmacological and surgical treatment to completely conservative management, and they experienced a really instantaneous and sustained increase in the proportion of death or BPD amongst their population. And it's not saying that this is incorrect, that a conservative approach is wrong, but it suggests, especially amongst smaller babies, that there in fact may be a proportion of these babies who may benefit from transcatheter or surgical closure. Ultimately, for clinicians to be confident about the decision that they're making, we need randomized controlled trial evidence. And a recent meta-analysis by Adrienne Bischoff, who's in Iowa, found that there were unfortunately no RCT evidence to answer the question of whether clinicians should choose transcatheter device closure or conservative management amongst preterm babies with PDA. So we're looking to whether there's any observational evidence of benefit, and there is some. And this is a retrospective study, again, from Nationwide Children's, where they took a cohort of babies who were treated with percutaneous closure and matched them according to important confounders with a historical cohort of babies who were managed just conservatively. They looked at their pulmonary score or their respiratory, the intensity of their respiratory support, and they found that amongst these closely matched babies, the babies who underwent percutaneous closure had a significant decrease in their pulmonary score, which was sustained for several weeks later. And of course, many clinicians who deal with babies with PDA are worried about pulmonary hypertension related to chronic exposure to a ductal shunt. And some of the recent catheter-based data provides an answer that this potentially is a problem. And this is data from Tennessee that examined 100 extremely low birth weight babies with PDA who were treated with a transcatheter device closure. And they found that almost 2/3 of them did have catheter-based evidence of pulmonary hypertension, of whom 44% of them were actually due to the PDA shunt, that they had flow-related pulmonary hypertension. And it suggests that this may be a subpopulation where you don't want to have long-standing exposure to a large ductal shunt. And further evidence from the group some seems to corroborate that, indicating that earlier transcatheter closure is associated with earlier weaning from respiratory support. And they group babies according to the timing of their closure, and babies whose PDAs were closed in the first month had a significantly lower respiratory severity score compared to babies where the transcatheter closure occurred later. Now, of course, this doesn't tell us exactly which babies to send for device closure or surgical ligation for that matter, but some data and some of our local data from Toronto may help elucidate that somewhat. And we found in a cohort of babies who were dependent on mechanical ventilation and who were sent for surgical ligation because they were mechanically ventilator dependent, we found that key echo indices that we all use and we all think are important in our assessment of PDA do in fact predict time to extubation, which is the major reason that we send babies for surgical ligation in the first place. In particular, we found that the larger the PDA diameter and the more dilated the left ventricle, the faster those babies were weaned from mechanical ventilation. And again, this doesn't suggest that we should send all babies for ligation, but it tells us that some of the echo indices that we use, actually, they may correlate and provide some validation that these maybe are associated with the respiratory insufficiency, which we wish to improve. So we've seen some observational data that there may be a population of babies who may benefit from transcatheter closure. And what about the babies who clinicians have committed early to conservative management, but when to pull the plug on that, when to seek rescue definitive closure after a failure of conservative management? Unfortunately, for this question, there's really a lack of evidence, and it really comes down to clinician preference. Some of the questions that are asked are we having difficulty weaning from mechanical ventilation or non-invasive positive pressure support? And of course, the assessment of this question depends on the clinician's perception of the progress anticipated from a particular baby. Some clinicians prioritize definitive closure for babies that suffer recurrent acute kidney injury or recurrent pulmonary hemorrhage. For other clinicians, it's poor growth, and for others, it's the evolution, slow development of chronic pulmonary hypertension that is felt to be related to increase in flow. So in closing, we've looked at that there are actually several indications with which to consider transcatheter device closure, but there's no firm answers at the moment. If you're a clinician where you have a baby and you feel strongly about committing the baby to some type of definitive closure, clinicians in general have, in centers where transcatheter device closure is available, have for the most part abandoned surgical ligation in favor of transcatheter device closure, even though there really is limited RCT. There's no RCT evidence, and it's really based on a perception that transcatheter device closure is less harmful. And again, Dr. Jasani is going to be looking at that in more detail. Secondly, if you're a clinician and you have the baby who's failed medical management and you're not sure whether to send them for definitive closure or to try a trial of conservative management, again, there is a paucity of evidence to guide our decision at the moment, and RCTs are needed. Until then, there is some observational lower quality evidence where it seems reasonable to consider device closure amongst the babies with large shunts and who appear to be experiencing complications of a large ductal shunt, such as difficulty in weaning respiratory support. And finally, for the third and perhaps more nebulous question of when to abandon conservative management, there isn't great evidence to support us. In general, the principle is it seems reasonable for clinicians to wait long enough, but don't wait too long. Unfortunately, we don't quite have metrics associated with that to help guide how long is too long. In terms of indications in the future, where may we be headed for transcatheter PDA closure? I think the next step is, given that this is an intervention that's only going to be administered to a small minority of our extremely preterm babies, step one is to optimize patient selection. We need to identify those babies at risk of having a persistent large PDA, as well as at increased risk of mortality and morbidity. And once that group is identified, the next step is to evaluate the intervention of transcatheter closure versus conservative management in an RCT. And I think a reasonable analogy is that's been brought up is whether this is relatable to PFO device closure for the prevention of recurrent stroke. And this was a topic for many decades where there was continued uncertainty, and it seemed to have been now solved with the creation of risk scores such as the ROPE score to identify patients at risk of recurrent stroke, and subsequently RCTs over the last 10 to 15 years that have shown that intervention in this high-risk group is actually able to reduce the long-term morbidity. So thank you again for the opportunity to speak today, and looking forward to our Q&A session later.
Hi, so my name is Lynn Lee, and I'm going to share with you just a little bit of our experience with creating a program for ductal device closure. So the objective is to describe the framework and the process to successful implementation of a new intervention program. For those of you who are not familiar with Canada, we have a population of approximately 37 million, for which the province of Ontario has 14 million people.
Sorry,
And
Dr. Lindley, it seems your slide is not advancing.
Okay, I'm at the Canadian side. Is it advancing?
No, it's not. You might want to try just stop share and then reshare your screen again.
Okay. And then can people see my slides?
I can see your slide, your first slide.
And the second?
Yeah, is,
And we're in Canada?
yes, yeah, that's the one.
Okay. All right. So
Thank you.
just as I was mentioning, that for those who are not familiar with Canada, we have approximately a population of about 37 million, for which a high proportion of our population lives in the province of Ontario. The Greater Toronto Area services about 6 million people currently. As Dr. Weiss had mentioned, is that the overall in the past decade, the number of PDA ligations has continued to decline. And this actually impacts in terms of what is offered at each center, such that when you ask, some centers are no longer offering PDA ligations, and their surgeons are no longer comfortable in offering this procedure, given the fact that they are doing it so infrequently. When we talk about implementations, it's important to highlight some of the steps that are important for discussion. One, performing a needs assessment, identifying some of the program adopters and implementers, identifying what are the outcomes that are of importance and the performance objectives, and what are some of the strategies that we will implement and what protocols will be required. And finally, the evaluation of outcomes. For us here in Sick Kids, we provided an informal assessment by polling and discussing with our neonatologists, both in our center here at Sick Kids, across at our two sister sites at Mount Sinai and Sunnybrook, and at least more broadly across the province, to say, would this benefit their neonatologist care of the preemie population, and based on the perceived benefits and complication rates. To start off with, we talked about sort of who would be eligible for the device closure. And we started off with babies who were less than 34 weeks gestation at a minimum age of at least 14 days of life, and at least greater than 900 grams. Our group felt that to offer this, although the Amplatzer device was available for and had been tested in smaller children, 900 grams was a good starting weight. There was a need for respiratory support and failure of or contraindication to medical treatment, as well as some of the echo findings of a moderate to large unrestricted PDA and entirely mostly left to right shunt. The teams that are involved are many. For us, it was really looking at the need for interventional cardiology, neonatal cardiology, the echo lab team, the many members of the neonatology team and transport services, cardiovascular surgery in the event that the duct was deemed not suitable for device closure or there was failure of the procedure, as well as involvement of anesthesia. It's important also to highlight the key roles and responsibilities from each of these teams, given the number of people that were required and that it is very resource intensive. So although teams were identified, a smaller working group was created to help with the implementation. And these included physicians, surgeons, nursing, educators, administrators, information clerks, and also trainees. In Canada, our healthcare system is regionalized, and the Greater Toronto region has a population, as I had mentioned previously, of 6 million people, for which there are 2 level 3 perinatal NICUs and Sick Kids as a quaternary NICU that provides surgical, neurocritical care, and subspecialty expertise. Collectively, we see about 15 to 20% of all infants born less than 1,500 grams in Canada here in the Greater Toronto region. And there is a well-established referral system and a hospital-based transport system that is located at Sick Kids.
Dr. Lindley, sorry to interrupt again. It seems your slide cutting off like on the edge, so we only able to see like 80% of your slide.
Okay, can you see this better?
Yeah, do you want to just duplicate or just swap to the display? Yeah, it's cutting out, Dr. Lindley.
Does this work a bit better?
Yeah.
Okay.
Yeah, I think it's good now. Thank you.
All right, sorry. Let me just go back up here. So the process actually identifies multiple steps. It starts from referral, triage, transport, admission, and follow-up. And it's so important to highlight that as we go through all these different steps, there are a number of teams that are involved. So it is important to develop a communication plan and identify education gaps for each of the different teams as we introduce a new procedure, as well as feedback to provide a timely ability to improve the process quickly. Here at Sick Kids, the referral is made through email and the echo images are uploaded to Sick Kids. The cardiologist determines the eligibility for the device closure or ligation. We establish a procedure date and the possibility that there may be need for operative closure and a backup plan is established. And an NICU bed is confirmed. And all these steps are completed prior to the baby being transferred here at Sick Kids. The call is initiated by the referring physician to Sick Kids to request transfer and admission. And we electively admit these babies 24 hours prior to procedure to ensure that all pre-procedure blood work and investigations are done in a timely manner so that everything is done efficiently and quickly. Prior to transport, our transport team also speaks to our referring physician and a repeat echo is done 24 hours prior to transfer. Given that the duct is a dynamic organ, it is important for us to ensure that the duct still remains open prior to transfer and for device closure. There is a trial of conventional ventilation for 2 hours. If the patient's on high frequency ventilation, and that is needed for us to be able to do this successfully in the cath lab, as well as pre-procedure blood work, COVID-19 pre-procedural swab is done, and avoiding any line placements in that right leg or groin. Upon admission, the outstanding blood work is completed, and we start the protocol for elective intubation and NPO as needed in anticipation of the procedure. Follow-up and post-procedure wise, we will complete a groin ultrasound and also a follow-up echo within 3 hours and 24 hours post-procedure to assess function and to ensure that the device remains well placed. I think it is important to highlight that some of the challenges that we have faced is really around ensuring that this echo is done in a timely way and the duct remains patent, as well ensuring that there has been no change in patient status from the timing of when the baby has been accepted for a device procedure and upon admission. So communication is key. We talked a little bit about education, and I wanted to just discuss the importance of nursing education as an example of the knowledge gap and the need for implementation by other teams. Because we have a separate cardiac critical care unit here at Sick Kids, for which many are patients who undergo catheter-based procedures will receive their post-procedure care, our nursing team was not familiar with the care required. And so we reached out to our cath lab nurses to develop an education program that was rolled out in subsequent workshops, as well as key education materials to our nursing to ensure that we were doing this safely. And follow-up was organized with cardiologists here at Sick Kids, if the family resided locally, or with a local cardiologist outside of the GTA, with echoes done at 1 week, 1 month, 3 months, and 6 months. Approximately about a year after we implemented this program, we had a conversation to discuss whether or not we had gained sufficient expertise to offer this more province-wide. And the team were in agreement that we were in a place, given that we had an opportunity to review our process, ensure that the appropriate communication handover and plan had been established, and to review our current sort of initial outcomes of the procedure. So this was now offered across the province. Furthermore, upon discussion with our team and the key leads, it was felt that we could offer it to smaller babies. So that this is the most updated pathway for procedural closure, and that we are now providing it to any baby who is greater than 750 grams and who would meet the criteria from both a clinical and an echocardiographic perspective. Thank you.
Hi, can you see my slides?
Yeah, we can see your slide.
Okay. My name is Vanessa and I'm from Sick Kids as well. And thanks for the opportunity to present on the anesthetic management of the Preemie duct in the catheterization lab. So by its nature and philosophy, pediatric anesthesia is at its best when undramatic and routine. Our job is to provide reliable and uneventful anesthetic care to often complex patients for technically challenging procedures, and to be able to act quickly and efficiently while maintaining outward calm, even if it's just a facade, when these cases become eventful. Preemie for PDA device occlusion is one such an example of a complex and technically challenging case. These premature infants would have benefited from being managed by NICU intensivists in a carefully controlled environment, and we expect that they would be optimized with respect to respiratory status and ventilator settings, temperature control, fluid and glucose intake. And our aim is to continue with this level of care with the resources that we have at our disposal in the cath lab. Pediatric cardiac anesthesiologists have been anesthetizing these tiny patients for surgical ligation in the operating room or in some centers in the NICU at the patient's bedside or cot for many years, with the known attendant risks and problems. However, this relatively new alternative method of closure in the cath lab in this particular patient population presents us with its own specific set of clinical and logistic challenges. Some of the specific challenges relate to the fact that the cath lab is considered a remote or satellite location, and hence does not have the luxury of the clinical support that the operating room has. And obviously, should something go wrong, we won't have that support. We do have to transport these patients to and from the cath lab, with the inherent risks associated with transporting a critically ill patient, coupled with the additional risk that these patients are pretty small, and issues like tube dislodgement or even just like minute migration can result in quite a dramatic change in the ventilator requirements. And of course, temperature regulation is an issue which translates into the intraoperative period as well, along with things like iatrogenic hemodilution and acute kidney injury secondary to contrast media. Intraoperative hemodynamic changes and ventilator changes during device manipulation, again, usually more manageable than when we do the ligation surgically, but can still be quite challenging. And of course, vascular damage, again, which if significant can be quite challenging to manage. Specific anesthetic management considerations, of course, the airway. We are anesthesiologists, so we do intubate in the cath lab patients that are greater than 2 kilos who weren't previously intubated. Babies less than 2 kilos, we've asked that our NICU intubates prior to transport. If they were previously intubated, if there is a big leak, we do request that they upsize the endotracheal tube. They don't put cuffed ET tubes in. If they can't get a larger on-cuff tube in, then we use a NICU ventilator, which can compensate for the leak. And then we request that the NICU RT remains during the case, or at least is accessible should we run into problems and need to troubleshoot the ventilator. The rationale, I think, is to eliminate the exposure of these very small infants to the cold environment in the cath lab during induction and intubation. And again, that clinical support, if intubation or ventilation isn't as straightforward as we hoped, because the support in the NICU would be a lot more robust than in the cath lab. And we believe that a secured airway simplifies patient transport and generally reduces the overall time that the baby is away in this remote location. Some centers actually, like Vince said, we do require that the baby is stable on conventional mechanical ventilation for at least 2 hours prior to transport. Some centers use the NICU ventilators intraoperatively for all cases. And I think the overall goal is providing more precise respiratory parameters than those possible with OR anesthesia machine or standard anesthesia machine. But we only use the NICU vent if high peak inspiratory pressures or PEEPs are required to ventilate the patient in the NICU, or like we said, if there's a big leak. My personal preference is to have the NICU sedate or must relax the baby, establish stable hemodynamics and ventilation on vent settings that I can probably mimic on my anesthesia machine prior to transport. And if, like we said, there's a big leak, then I get them to bring the NICU vent up. Access is a big issue. Usually, the patients will come with a NICU pick, and it's usually infused in maintenance fluids, dextrose containing maintenance fluids. It's actually quite difficult to push meds and flush these NICU picks. And for sure, we cannot transfuse pack cells. So ideally, we like a peripheral intravenous present. And preferably established prior to transfer, again, to reduce the exposure of the baby to the lab and the time away from the remote location. If the baby comes to the lab with no peripheral intravenous, then we usually establish one. Fluid restriction and diuretic therapy are sometimes used as adjuncts in the treatment of PDAs and early BPDs. So this may contribute to hypovolemia and severe hypertension during anesthesia, and we're cognizant of this, and we look out for this and we manage accordingly, especially if we do an inhalational or maintain with midazolam. Transport and temperature control. We do have a dedicated NICU transport team. So the baby is transported by this team in a pre-warmed transport incubator with built-in ventilators. And so that's usually not an issue in terms of the transport to and from. And of course, we do a NICU huddle pre-transport, including the intensivist, the bedside nurse, the RT, anesthetist, of course, interventionalist, transport team, and basically we want to make sure that the entire team is on the same page. They summarize the patient's clinical course. For us, important, like the tube size, if they've had any issues with the ventilation, most recent parameters, most recent labs, make sure there is actually blood available for the case. And then we do a quick dissertation on the anesthetic or cath plan, usually very quick. Intraoperative anesthetic management, so monitoring. If the baby has an arterial line in situ, then we will transduce it. We don't put an arterial line in for the case. Standard ASA monitoring. End tidal, of course, is very important. Trends, presence or absence of end tidal, more important than absolute numbers, because we know there is like a variability when there is a big leak. Blood gases, again, we only do when absolutely indicated, because we're quite mindful of bloodletting in these small patients. And the things that we would be looking for, the electrolytes, especially things like glucose, potassium, calcium, and hemoglobin, because we are cognizant, again, that there may be hemodilution from the contrast medium. And usually we get the gas from the cath access. We try and increase the ambient temperature of the lab before we bring the patients in. We do use forced air warmers, so a bear hugger, underbody bear hugger, and we we try and preponderate the baby as quickly and efficiently as possible so the time that they're exposed is as short as possible. In terms of the general anesthetic, I think it's more important how we use what we use versus what we actually use. Some centers use just a narcotic-based anesthetic versus ketamine. Some centers use just midazolam. Some centers actually avoid inhalational agents, and I think their concern is for worsening diastolic hypotension in patients with pre-existing left to right shunts and an effect on surfactant. Hemodynamics, again, we manage these saturations and hypotension as we would in any case, specifically for these patients, because we know that the endotracheal tubes are actually quite tiny. They can become blocked quite readily. If we think it's tube related, then obviously we're going to suction. If we think it's dependent on what the interventional cardiologist is doing, then usually they're pretty good at communicating this with us, and we will wait before we troubleshoot from our end. Hypertension, we manage accordingly, again, based on what the likely cause is. If it's obvious bleeding, then we will give volume. If it's due to our level of anesthetic, then we will adjust that. And post-operatively, these patients are transported, sedated, may or may not be muscle relaxed, depends on the anesthetist, and again, by the dedicated NICU transport team. And once we get to the NICU, we round everybody up again and we do a post-operative huddle. From an anesthetic point of view, the information we make sure we tell the NICU team how much sedation we gave, what we gave, when last we gave a dose, muscle relaxant if we did. If we needed to give more volume than normal, then we would tell them how much. If we had to transfuse, things like that. If we had any particular issues with ventilation, or if we had to go up on our ventilator requirements significantly, then we will tell them that, or any adjustments to the tube that we made. So a group out of University of Texas Health Science Center in Houston actually did a single center retrospective study reviewing their data of all infants who underwent closure of PDAs in the cath lab between 2015 and 2019, who weighed less than 3 kilograms at the time of the procedure. And about half of their patients were less than 2 kilos, their smallest being 490 grams. And I think their largest being just under 3.2 kilos. They looked at a total of 76 patients, 43 of whom were intubated just for the procedure. And their anesthesia team, along with their cardiologist and neonatology colleagues, actually came up with this protocol that they recently published. And you can see it's not very different from what we've been doing. And their procedure-related complications, again, not that significant. As you can see, there were no anesthesia-related hemodynamic instabilities. 5% did require red blood cell transfusion, and 3% suffered from hypothermia. What they found quite interestingly, though, is that 40% of the patients that they intubated just for the procedure required prolonged intubation, so more than 3 days post the procedure. And they attributed this to underlying parenchymal lung disease, so prematurity, pulmonary overcirculation, coupled with the fact that they did keep them sedated on like a morphine infusion or a dexmedetomidine infusion just for the post-op day one, and they thought maybe that contributed to why it took so long for them to wean and extubate. But they did conclude that despite the challenges, the anesthetic risk associated with this procedure in these small neonates can be effectively managed through like a standardized and multidisciplinary care. Thanks.
Thanks, Vanessa. So I'm just going to talk to you all today on the role of echo in the management of PDA. So echo is really used at all stages of the management of PDA, both before, during, and after any interventional procedure. Before, we use echo to both rule out congenital heart disease and also to perform a hemodynamic assessment, as well as assess the suitability of the duct for intervention. During the procedure, we use it to assist in accurate device placement and also to confirm the LPA and arch integrity. And after the procedure, we use it to identify post-PdaLigation syndrome, confirm the device placement, and monitor for any potential complications. So once a patient is referred who is symptomatic from PDA, we outrule duct-dependent or other major congenital heart disease on echo. And then secondarily, we look for echo evidence of a large left to right shunt, followed by a determination of the suitability of the PDA for an interventional procedure. When it comes to, is there evidence of a large left to right shunt, really in this population, what we really look for is there evidence of left ventricular or left atrial dilation. And of course, there are other secondary things that we can look for in addition, which would include flow reversal in the abdominal or thoracic aorta, flow acceleration across the mitral valve, and dilation of the branch pulmonary arteries. But it really is left ventricular dilation that we look for primarily in the presence of a large PDA in this population. When it comes to determining the suitability of the PDA for an interventional procedure, firstly, we look at its dimensions. And when I talk about dimensions, I mean the length and the width. And typically in these babies, the PDAs tend to be greater than 2.5 millimeters. And whenever they get 5 millimeters or above, that's probably too large for a device, a safe deployment of a device. And again, when it comes to length, the reverse is true. So the shorter the length of the PDA, the more unsuitable that would be for an intervention. We would want to confirm the direction of the shunt, which we would want to be left to right in systole, indicating a lower pulmonary artery than systemic pressure. And then lastly, I look at the morphology of the duct, providing both a descriptive assessment as well as morphological categorization. So let's get on to some clips. So whenever we, as I mentioned, whenever we assess the hemodynamic significance of a PDA, what I look for is dilation of the left ventricular and left atrium. On the picture on the left is the parasternal long axis view. You can see that there is dilation of the left ventricle in comparison to the right, as well as dilation of the left atrium. By putting color Doppler on, we can see that there's some degree of mitral regurgitation, again, which is common in these patients, and it's usually due to dilation of the mitral valve annulus. Again, in the parasternal or in the apical fourth chamber view, you can see that the left ventricle and left atrium are both dilated. The atrial septum bulges towards the right atrium, indicating a volume-loaded left atrium. And again, with color Doppler, you can see flow acceleration across the mitral valve. And with the use of continuous wave Doppler, we can see a mean gradient of 7 millimeters of mercury across an anatomically normal mitral valve. Again, from the subcostal image, we can see the atrial septum bulging towards the right atrium. And then pulse wave Doppler of the abdominal aorta shows flow reversal throughout diastole. The branch pulmonary arteries also can be dilated due to the volume load, and we do see continuous flow into the branch pulmonary arteries from a continuous left to right shunt through the duct. When we look for the suitability of the duct, as I mentioned before, we want to look at the length, the width, and what type of duct it is. And the best place really to determine this is in the ductal view. So that is where we see both the aorta, the duct, and the left pulmonary artery. And in this case, this is a sweep from the aorta through the duct towards the pulmonary artery. You can see that this is a pretty standard duct in this preterm population. It's long, tubular. There's some restriction at the pulmonary artery end, and the shunt is entirely left to right. More imaging of that same patient. So here, picture on the left, we can see the aorta and the duct. And the duct you see is larger at the aortic end and does narrow somewhat towards the pulmonary artery end. So this would be a type A duct. And the shunt by color Doppler is left to right. We always confirm the shunt direction with continuous wave Doppler, and you can see here the shunt is entirely left to right and it's continuous. In this particular patient, the duct was restrictive to pressure with a peak gradient of 83 and a mean gradient of 38, indicating a low pulmonary artery pressure. When we measure the duct in this case, we measure from the aortic end to the to the end of the main pulmonary artery. And in this patient, the duct measured 9 millimeters with the width of between 3 and 4 millimeters, which would be really an ideal candidate for an interventional procedure. This is another example, again, of a very typical or suitable patient for an interventional duct closure. So the image on the left, you can see the right pulmonary artery, left pulmonary artery, PDA, and aorta. This would be a nice, image or an example of a ductal cut. Just by looking at this, you can see that this is a large PDA, as the PDA is really the same size as the branch pulmonary arteries. And when we apply color, again, you can see that this is a continuous left to right shunt. In this case, there was a low gradient between the aorta and the pulmonary artery, indicating high pulmonary artery pressures. And you can see here that there is no restriction at the pulmonary artery end. So this really would be a type C duct. So this is a tubular or finger-like duct. In this case, the duct is much larger and it's quite tortuous. So this is an image of the branch pulmonary artery. So the right pulmonary artery and the left pulmonary artery with continuous flow. You can kind of see the duct, which takes a tortuous course going behind the left pulmonary artery, entering the main pulmonary artery, just out of image here. And then you can see here on the image on the right, or the movie on the right, you can see how large that pulmonary artery is. And in fact, the PDA is, and in fact, it's larger than the branch pulmonary arteries. And in this case, the left pulmonary artery measured 4 millimeters and the duct measured at its widest point over 5 millimeters. And this would be a patient that would require careful consideration for the suitability of the patient for a cath procedure. And in these cases, we would typically perform a huddle where we would involve the echocardiographers, the interventionists, the neonatologists, and the surgeons, as well as the other members of the teams, to discuss which is the best option, whether it's surgical or interventional. And then lastly, the other type of duct that we typically see is a short PDA. What we've seen is that the older the patients, the duct tends to be shorter. So this is probably a baby who's greater than two weeks old. And you can see how short this duct does appear in comparison to the other examples that I showed you. This duct only measures about 4 millimeters in length and about 2.5 millimeters in width. So this again would be on the other extreme, where the duct would be too short, potentially too short for an intervention. So whenever the procedure is being performed, the echocardiographer is in the cath lab performing a transthoracic echo at the time, to both assist in the placement of the device, but also to confirm the integrity or the patency of the left pulmonary artery and the aorta. So this is an example of placement of the device in the cath lab. So you can see the catheter wire crossing the pulmonary valve through the MPA with the device sitting in the duct. Importantly, you can see the LPA labeled here, and really there's no narrowing or impingement of the origin of the left pulmonary artery whatsoever. And again, with color, you can see that there's no flow acceleration into the left pulmonary artery. There's a small residual shunt here, which some people refer to as the flame sign, which would be an acceptable amount of shunt. And then we always examine the aorta. And whenever the device is still attached to the wire and under some tension, it can have the appearance can look like it's bulging into the aorta. So we always confirm that both the LPA and aorta are unobstructed with Doppler, and you can see here they're very normal, both color and continuous wave Doppler profiles. Whenever the device is released, this is its final position. So starting with the image on the left, this is like a ductal cut. So you can see the left pulmonary artery, you can see the device in the PDA, and then the aorta. So it's always very important when you are confirming the placement to make sure that you see the aortic isthmus and not just the thoracic aorta, as this really is the area that can be impinged by a device. And secondarily, you want to see that the origin of the LPA is unobstructed. And in this case, the device is positioned perfectly. So it's far from the origin of the left pulmonary artery, and the aortic isthmus is intact. And you can see that here both by color. And then in the left pulmonary artery, you can see there is some flow acceleration, which is not uncommon. So following placement of the device, we echo babies at 4 hours following the procedure, as well as 24 hours routinely. And this is to look for, as Danny mentioned before, PostpdaLigation syndrome, which probably needs to have a new name if they have an interventional procedure. But this, it's rare in the sense that it occurs in maybe 5 to 7% of patients after a procedure. But as you can see in this case, it can be quite dramatic with severe left ventricular dysfunction. Sometimes these babies are symptomatic, sometimes they're asymptomatic. Typically, the NICU manages them either conservatively or if they're symptomatic with milrinone and sometimes diuretics. It's important if you do see an echo like that 4 hours after placement of the device, it's always important to confirm that the device has not moved, and the reason for dysfunction is not because of arch obstruction, for example. So in this case, the device was in a perfect position with an unobstructed branch pulmonary artery and aorta. And then 24 hours later, or the following morning, there was a resolution of the dysfunction, and it returned to normal. Sometimes we see tricuspid regurgitation, either due to just chordal inflammation or sometimes cord rupture. And in this patient, there was a rupture of one of the cords of the mitral valve, tricuspid valve, causing tricuspid regurgitation, which clinically is very well tolerated, even in these small babies. And you can see that both in the parasternal long axis view and also in the 4-chamber view. But importantly, this tricuspid regurgitation resolved on follow-up with being just trivial. Again, always on follow-up, no matter what we do, we always tend to look for the device, which you can see here, which is not obstructing either the left pulmonary artery or the aorta. The most common complication following device placement is LPA stenosis, and this is a nice example of that. Here you can see the right pulmonary artery, which is a nice size, and the left pulmonary artery, you get a sense that it is smaller or obstructed. And whenever you see the device, although it is in the duct, it does appear that the proximal end does protrude somewhat into the main pulmonary artery, compromising the left pulmonary artery origin. And that really becomes apparent when you put color Doppler on, and you can see that, firstly, the size discrepancy in the branch pulmonary arteries, and then secondarily, the flow acceleration and the fact there's continuous flow into the left pulmonary artery. And again, from like that ductal cut, you can see although the aortic arch is unobstructed, you can see the device placed here and how that it's compromising the origin of the left pulmonary artery. In this particular case, we performed a CT scan, which showed, which really confirmed that. So there was narrowing of the origin of the left pulmonary artery, but distally the vessel was fine. And in this particular case, due to the fact that this patient was rather preterm and had a lot of other comorbidities, we elected to stent the left pulmonary artery. And then subsequently, when he was, I think, 7 or 8 months old, he underwent LPA-plasty and removal of the PDA. And then the other big complication that is reported is obstruction of the aortic arch. So in this case, you can see this was the echo performed 4 hours after the baby had their procedure. There was, of course, severe left ventricular dysfunction. And you can see here that the device, or the distal end of the device, the aortic end of the device, does look like it impinges on the aortic isthmus. So the left subclavian artery is here. So then after the subclavian will be the isthmus. And again, that's confirmed with color. In the ductal view, you can see that although the LPA is not compromised, you can see that the device is positioned in the duct, but as I said, the aortic end does protrude into the aorta, causing narrowing at the isthmus, and there is likely a residual shunt, which you can see here. By Doppler, there was a high gradient with a continuous flow. And the abdominal aorta was, of course, very abnormal with low velocity and a very delayed upstroke. In this particular patient, they underwent surgical removal of the device and aortic arch reconstruction. So to conclude, echo is used really, as I said, at all steps in the management of PDAs, and initially it's used for the identification of suitable patients. It does help in the more accurate placement of the devices during the procedure, and it is used for the detection of complications before they become clinically evident. Thank you very much.
Hi, I'm going to be talking about the implantation procedure, focusing on the technicalities and principally on babies that are 1 kilo plus or minus a few hundred grams. And it's based on our practice in Toronto. I've no disclosures. So at that weight, the most commonly used device is the Piccolo. I'll mention briefly the AVP2, and there are a few other devices like the MVP that are used, and there are new devices being developed all the time. So this is a blow up of one of the Piccolo devices. The most common sizes used are the 4.2 and the 3.2. The 3.2 has a retention disc that's 4 millimeters. The 4.2 is a retention disc that's 5.25 millimeters, and the 5.2 is 6.5. Okay. So the results of the Piccolo trial, single arm, were published at the end of 2020. Involved 9 centers, 200 babies, all over 700 grams. There were 100 that were less than 2 kilos. There was a very high implantation success of about 96%. And for those less than 2 kilos, it was 99%. device embolization occurred, but importantly, all of these could be retrieved in the cath lab. 5 occurred during the procedure and 2 after the procedure. And in one of these cases, the retrieval of the device led to the duct going into spasm or getting a dissection. And a second device did not need to be implanted. And I've certainly had that experience. In 4 patients, the primary safety endpoint was crossed. 2 required a transfusion, 1 had hemolysis, and 1 had aortic arch obstruction. At 6 months, there were no cases of LPA stenosis. There were, however, 5 cases of new tricuspid regurgitation that was moderate in degree. All were less than 2 kilos, and 2 had a history of device retrieval. And at 6 months, 3 still had significant tricuspid regurgitation. 1 had died from unrelated causes, and 1 was out of the study because the device was retrieved. And at 6 months, closure was very high, 100% in those less than 2 kilos, and 99% in those above 2 kilos. Now, the technique of closure is well described in that reference by Evan Zahn, and it's worth reading if you're intending to do these procedures. We obtain ultrasound-guided access, use a 4 French sheath. Operators vary in whether they use heparin. I use 50 per kilo. To cross the tricuspid valve and reach the pulmonary artery, you have a choice of either crossing with a balloon end-hole catheter with the balloon inflated, or having your catheter in the right atrium pointing across the tricuspid valve and using a floppy wire and manipulating that into the pulmonary artery. Following that, a 4 French glide cath is advanced. This can just be a typical, just an angled glide cath, or it can be a JB1. In the PA, or once you're in the duct, PDA angiogram is performed using a hand shot, and this can be over the wire if you prefer. In the A plane should be angled LAO and caudal to separate out the LPA from the duct. A straight lateral for the B view, and it's very useful to have a nasogastric tube in place to mark the aortic end of the duct. And then over a 035 wire, a 4 French delivery sheath, the torque view LP is deployed. The major problem with the current delivery system is the delivery cable is too stiff, and you'll see some of the consequences of that. And this is probably the most important message in this talk, that unlike the usual ducts that we're used to, the device should be delivered wholly within the duct, completely within the duct. And this avoids aortic obstruction and LPA obstruction. If you're too close to the PA end, even if you're within the duct, you can still press on the LPA. And this is a sizing chart based on the Memphis recommendations. I'm talking principally about these babies. Once you get to the above 2 kilo, there's a wider range of devices that need to be considered to cope with all the different anatomies. I'm going to focus mainly on this. Okay, so here you have a typical angiogram in a large duct in a baby that's 900 grams. Large duct. On the A view, it's difficult to know exactly where the aortic end is. You'd guess it was somewhere around about here. This is the LPA, RPA, and here you have a large feeding tube. Here's the endotracheal tube. And then if you go to the B view, you can see the feeding tube, the anterior border overlies the aortic end of the duct. If there's a PICC line in the SVC, it will usually point towards the PA end of the duct. So that can be an additional useful marker. This duct measures 11 millimeters, so it's long. We'd consider anything over around about 7 millimeters to be a long duct. And it's wide in the mid portion, measures up to 4.1 millimeters. And so it started off with the 5.4. This is too big. The device is too proximal. You can see the PA disc, which overlies the feeding tube, looks like it's just about to pop into the MPA and produce obstruction. The angiogram is reassuring. There doesn't seem to be any severe LPA constriction, but it just looks too ugly to leave. Okay, so then downsizing to a shorter device, and now the device is too deep. It doesn't look too bad under fluoroscopy. You've got quite a bit of duct here, so it's quite deep into the duct, but you can see this aortic disc is overlying the feeding tube. And then if you switch to the echocardiogram, you can see that the device is far too deep into the aorta. Okay, and then the final device that was used was a 4-2. Now, just if you look at the still, you can see there's quite a lot of length of duct between the end of the PA disc and the MPA. The duct, the device is also lying just to the left of the feeding tube, which is reassuring when you see that. And you can see that there's no obstruction to the LPA. And then on the B view, you can see that the device is far from the anterior border of the feeding tube, and you've got a good length of duct here. Okay, and then just to confirm by echo that there's no obstruction, and this is very similar to some of the views Conal showed. Okay, so for babies less than 1 kilo, there's not a lot of space, so it's easy to damage the heart. And so the tricuspid valve, obviously, but even when you get into the right ventricular outflow tract, this in principle seems reassuring. You've got the glide cath here. You've got a wire going into the MPA across the duct and into the descending aorta. All should be well, but the glide cath won't advance. And if you do a hand shot, you see what the problem is. A false passage has been created. So the true native route is here, and the catheter is here. And then on the A plane, you can see that, again, the wire is in the duct, but there's a bit of staining of the pericardium. So you just have to take the wire and the catheter out and start all over again. Okay, then when you do advance to the correct RVOT, rather than create a new one, you can see a typical duct, large duct. We have the feeding tube in place marking the aortic end, and you can see it constrict towards the PA end. So this is 9 millimeters wide. At its widest, it's 5.2 millimeters. And here we have a recurring problem that because the delivery system is quite stiff and these ducts are long and mobile, you can lose your baseline anatomy. Here, the device has swung upwards, so it's now pointing cranially rather than pointing caudally. And now all your anatomical landmarks have been lost. So this is the feeding tube, and that should mark the aortic end of the duct. But you can see if you do a hand shot that everything has been pulled anteriorly, and the device and the aorta has been pulled forward, and the device is deep in the aorta, in the descending aorta. And this is a recurring situation, and you have to be very careful with your landmarks with the echocardiography to confirm you're not obstructing the aorta. And in this particular patient, it required multiple passes and very careful use of the A plane and rotation of the sheath medially using the 8th plane to confirm that the whole delivery system wasn't swinging to the left, and the device had to be partially extruded to anchor the delivery system in the duct, and then pulled in and then pushed out again in a kind of push-pull manner to retain the orientation of the duct. Okay, and then this is the final position of the 3-2 piccolo, and you can see it's probably a little bit too deep. It could be a little bit further into the aortic end, but it's well within the duct. It's not sticking out of the PA. There's no LPA obstruction. So in conclusion, these devices should be deployed completely within the duct. In babies less than 1 kilo, you have to be very careful. There's very little space for maneuver. There's little fibrous tissue within the ventricles and the outflow tract, so it's easy to perforate these hearts. You really shouldn't release the device until you're sure. Even if the baby's desaturating, it's better to take stuff out of the heart and start again rather than to deploy when you're not sure. You can frequently retrieve the device, but if you do need surgery, you're going to need cardiopulmonary bypass. So that's a big consideration to be sure that you're confident of device position. And that comes principally by echocardiography. Aortic obstruction is going to be imaged by the echo, and LP obstruction can be imaged by angiography as well as by echocardiography. Less than 2 kilos, you're principally thinking of using the Piccolo device. Over 2 kilos, there's a wider range of devices and wider range of anatomies. And it, in a sense, becomes more complicated because you have more choice. That's it. Thank you very much.
Thank you, Dr. Chaturvedi. Thank you, Rajiv, for walking us through all the steps in device implantation. I would like to extend a warm welcome to all the attendees for sparing their valuable time to attend this fantastic webinar on contemporary management of PDA in preemie infants. I would also like to thank the organizers, the interventional cardiology team, for extending this opportunity to present this important topic. And for people who don't know me, I'm Bonnie Jasani, staff neonatologist and assistant professor of pediatrics, affiliated to Sick Kids and University of Toronto. And I'm the NICU hemodynamic person working closely with cardiology and interventional cardiology. The topic of my presentation is to evaluate outcomes, especially effectiveness and safety of percutaneous closure and surgical ligation of PDA in preterm infants. I would like to disclose that I don't have any financial relationships or conflict of interest declare. Since the first reports, successful reports of successful closure of PDA with coil or device placement in preterm low-weight infants almost 2 decades back into 2009 from Japan and India, there has been a renewed enthusiasm across the globe for percutaneous closure of PDA as an effective and safe alternative to ligation. Over the past decade, we have seen this procedure being conducted with increasing success, primarily because there have been a lot of device modification, as Rajiv said, and secondly, because there has been a shift in the approach from an arterial approach to a transvenous approach, especially in infants less than or equal to 2 kilos. The focus of my talk is pertaining to 3 main subheadings. To evaluate outcomes of percutaneous closure of PDA in infants, in preterm infants less than or equal to 1500 grams. Simultaneously, since we have launched this program at Sick Kids, we'll be looking at outcomes of infants less than or equal to 2000 grams at Sick Kids. And lastly, do a head-to-head comparison of percutaneous closure versus surgical ligation of PDA in preterm infants. So a group of researchers from Toronto and US, spearheaded by Adrian, myself, and Danny, and a couple of others from Memphis, Iowa, our objective of our systematic review and meta-analysis was to evaluate effectiveness and safety of device placement in preterm infants who are less than or equal to 1500 grams with PDA. We searched all databases for relevant studies from inception till April 2020, dividing into a whole population into less than or equal to 1500 grams and 1500 grams to 6 kilos. The primary outcome of our review was technical success. Technical success was defined as a patient leaving the catheterization suite with a device or a coil successfully implanted in the PDA. Any deviations from this were deemed as failure. We also evaluated secondary outcomes. We looked at major adverse events, including what Dr. Connell and Rajiv mentioned, migration of the device to descending aorta, causing iatrogenic coarctation of aorta, LPA stenosis, thrombosis needing anticoagulation. We also looked at IVC dissection, IVC perforation, and some minor adverse events. And lastly, most importantly, procedural related mortality. Coming to a primary outcome, we found 28 observational studies. We did not find any randomized controlled trials enrolling 373 infants less than or equal to 1500 grams. The overall technical success rate in this systematic review was 96%. Of interest, out of these 373 infants, 75 infants were from the Piccolo trial, which Rajiv just mentioned, and many infants were from Memphis Group, which is the world's largest center for conducting transcatheter closure of PDA in ELBW infants. At SickKids, we have done this procedure in 52 infants so far. In less than or equal to 2000 grams, we have done it in 43 infants. And the overall technical success rate in this subpopulation of less than or equal to 2000 grams is 91%. Let's look at the common reasons for failure. Worldwide, there were 10 cases in less than or equal to 1500 grams which failed, 3 cases each of cardiac perforation leading to hemopericardium, 3 cases of inability to place a device because the duct was too large, and subsequently needing surgical ligation. And the other causes were IVC dissection, aortic coarctation, cardiac tamponade, LPA stenosis, and intraluminal PDA dissection needing device removal at SickKids. If we have to look at from the lens of baseline characteristics, in our systematic review, we found that the mean weight at the time of procedure was 1060 grams. The mean age at the time of procedure was 29.5 days. And the device which was most commonly used was the Piccolo device in 65%. Since 2019, since we have launched this program, the mean weight at the time of procedure is 1253 grams. The mean age at the time of procedure is 43 days. And we have the device which is predominantly used at SickKids is the Piccolo in 88% of the cases. We were very reassured when we looked at our safety data at SickKids. If we compared the post-procedural mortality, there were none cases at SickKids where there were 2% cases, 5 deaths in total in our systematic review. Interesting to note that out of those 5 deaths, 4 babies were less than 800 grams. The major adverse events rates were 8% globally versus 7% at SickKids, and our minor adverse events rates were significantly less at SickKids, 9% versus 19%. The major adverse events at SickKids, I'll quickly skim through these because Connell has described them. We had a baby who had coarctation of aorta secondary to device migration, LPA stenosis needing LPA stenting. It was a late LPA stenosis not detected in the initial scans, and subsequently when he was 8 to 9 months old needed LPA plasty. And one baby had an intraluminal dissection which eventually closed the PDA, but we could not successfully implant a device. If we look through from 2019 to 2021 to see how many babies have we done. So in 2019, we did 13 babies In 2020, there were 25 babies, quite a busy year for the NICU and intervention cardiology department. And in 2021, so far, we have done 5 babies. And as you can see, we have steadily improved. We have moved our corrected gestation and postnatal age by almost a week. So there are early referrals from our perinatal centers and from other centers. And we are constantly striving to get referrals as early as 29 weeks and as early as a month of life. From the weight perspective, we have almost initially in 2019, the mean weight was 1353 grams. And in 2020, we have almost improved and we have come down to almost 1200 grams. A very interesting observation in our systematic review was the technical failure of the procedure is inversely proportional to age at the time of procedure. Earlier the procedure is done, there is a high probability of technical failure, and almost after 20 days of life, the probability of technical failure is less than 3% and none at around 40 days of life. When we evaluated this relationship, age at the time of procedure was a significant predictor for technical success, even after adjustment for weight, type of device, and year of publication or procedure. We wanted to explore the relation as comparing centers who had low volume of cath closures versus high volume, and expectedly the centers who were doing more volume of patients had less adverse events rates, especially major adverse events rates in comparison to centers who are doing less than 10 patients. So this is a very interesting slide. I looked at the need for inotropes at sick kids because there's an overarching feeling amongst neonatology and cardiology that the need for inotropes is less. The overall milrinone use was 24% and moderate to severe LV dysfunction was 26%. The postulated mechanisms to use milrinone, it's difficult to ascertain the true incidence of PLCS because we are getting the first echo within first 4 hours of life, first 4 hours post-procedure. It could be secondary to increase in afterload. Clinicians reacting on the post-procedure echo showing mild to moderate LV dysfunction and starting milrinone. Or lastly, in a select subset of preterm IUGR infants who have recurrent AKI, this is a postulated hypothesis that they could have an overactivated renin-angiotensin-aldosterone axis, which can lead to systemic hypertension, and the clinician would elect to start milrinone just in face of blood pressure shooting over 100 millimeters of mercury. The last focus of my talk is to do a head-to-head comparison of percutaneous closure versus surgical ligation of PDA in preterm infants with hemodynamically significant PDA. And we looked at a primary outcome was failure of PDA closure, and secondary outcomes were multiple, but I'll focus on rate of major adverse events, need for inotropes, and time to return to baseline respiratory severity. There were 8 observational studies, including 597 preterm infants, and there was no significant difference between the 2 groups with regards to failure to close PDA. The major adverse events were also not significantly different between the 2 groups. There were a high incidence of adverse events in surgical ligation group, which Danny has rightly elucidated to, high incidence of chylothorax, vocal cord paresis, PLCS, but that was offset in this forest plot by LPA stenosis, IVC dissection, aortic coarctation. But what was interesting to see, in contrast to what we see at sick kids, the need for post-procedure inotropes was nil in the TCPC group in comparison to ligation, and it was significantly different between the 2 groups favoring the transcatheter percutaneous closure. And lastly, I think the biggest advantage of percutaneous closure that these babies return to baseline respiratory severity, which is calculated by respiratory severity score, almost a difference of 24 hours. And we are further reached out to authors to get data on time for extubation, time to return to RSS less than 1, which I think would favor percutaneous closure of PDA. So the key messages from the various systematic reviews conducted by our group is percutaneous closure is effective. It is a safe alternative to ligation for PDA management in low weight preterm infants. It may have advantages over ligation, being less need for inotropes, less time to return to baseline respiratory severity. And we are conducting a case control study at sick kids just to see what is the time needed for these babies to get extubated and for weaning of respiratory support. Thank you. I would encourage the attendees to post questions on the Q&A group because we'll be opening up the house for questions, and we are most happy, the entire group is most happy to take questions from the participants.
Wow. There are some questions, Alexandra, maybe.
Yep, perfect. So great. Thank you so much for all of our wonderful presentations from our panelists. So as discussed, we'll now be opening up the question and answer period. So we'll start with the general question first. In older and bigger patients, we don't follow long-term post-duct occlusion. Do you recommend longer-term or lifelong follow-up in these patients?
I might be able to answer that at least partially. I've been following these patients, almost all of them that we've done in sick kids for the last 2 years. I haven't seen any late complications past the kind of inpatient, 2-3 months following the device. So I suppose I don't know the answer to that, but I've been following them for about 2 years. I haven't seen any complications, so maybe pretty infrequently after that point, but I'm not entirely sure.
Hi, thanks, Connell. Yeah, on reviewing all the published studies, observational studies, none of the centers across the globe are following beyond a year of age, and they have a fixed protocol to follow every 3 months in the first year post-procedure.
Yeah. I think it's very reassuring what you're saying, Connell. I guess we really don't know what the long-term implications are. What one would think as the chambers grow and the like, that this little tiny plug is going to be pretty insignificant. But when implanted in a kilogram baby, you don't know long-term.
I think it also depends that some of these babies are going to have significant BPD and are going to be followed by medical services anyway. So some of them get longer follow-up because of everything else apart from the duct.
Yep.
Fair enough. Thank you. This one is for Rajiv. Do you think the MVP device is softer and the cable not as rigid?
Yes. It is, and we don't have as much experience with it, but it is softer.
Okay, and then do you have neurodevelopmental follow-up on those undergoing transcatheter closure?
So we routinely follow all the children who are less than 29 weeks gestation in our neonatal follow-up programs across the Greater Toronto region as well as Ontario. So all that data, I see it's Dr. Sasha who's asking, all that data will be available. They just need to grow a little bit more and age a bit more.
Thank you. And if there are no complications or residual lesions, at what time can the patient be discharged for good from the cardiology follow-up?
So I think it's partially a repeat of the earlier questions. So there's the acute follow-up in the first 24 hours. For some of those that have a more prolonged post-ligation syndrome, it's been a little bit longer. But these babies are in our NICU, and I'm sure one of the neonatologists will chip in, but they're in our NICU, and so they're typically transferred in from outside, and so they would stay with us for let's say 48 hours roughly, and then they get transferred back to their host institution. And then there's still some monitoring, typically in-house by the neonatologists. And then when they're discharged from their NICU weeks to months later, then there's follow-up with cardiology, what Conal was describing, of 1 to 2 years, seeing them 3 to 4 months.
That's absolutely right, Rajiv.
Have you looked at severity of BPD in those undergoing transcatheter closure? Are you planning to take a look at this?
Danny is spearheading that project. We are planning to look at all the respiratory indices and neonatal morbidities of babies who have undergone transcatheter closure in comparison to babies who have undergone surgical ligation.
I mean, I think this is the big question that we'd all want to know the answer to, of not just closing the duct and getting rid of the shunt, but does it make a big long-term difference?
Yeah, when you say that, I always wonder, when I look at all the papers, many of which Danny touched upon, the time that the duct was intervened upon, whether that was surgically or in the catheter laboratory, varies quite a bit. I think that if you're going to make a comparison, or to actually find out if the intervention makes sense, you have to have a very standardized time of intervention, whether that's 2 weeks of life or a month of life, because the associated comorbidities just layer on top of one another. I think that also that the earlier you intervene from a technical standpoint, the duct is longer, so it may actually be advantageous to intervene earlier in life, but fairly standardized if you're going to do an RCT type of evaluation.
So I think all of us have been trying to get these babies in earlier, and some of the limiting factors are that it takes time to go through your non-steroidals, going through the iterations of that, and then they typically get an infection or they get something else, and so they get held up at their host institute just the night before transfer.
Bonnie, based on, you had one slide where you were looking at the ideal age for the intervention.
Yes, so based on Philip's latest paper in 2021, which Danny presented a snapshot, any baby who underwent catheter closure after 8 weeks had significantly poor respiratory course and high incidence of pulmonary hypertension, and babies who had done procedures within less than 4 weeks had better outcomes. So I think 4 to 6 weeks is if we can get patients by 4 weeks, that would be ideal. That's what's replicated in a systematic review by 29 days. If this procedure was done, high success rates and quicker respiratory recovery.
Thank you. Is there a role for hydrocortisone administration post-op?
For the physician or the baby?
So, Danny, you want to answer it? We are actually looking at it. Yeah, Danny, please go ahead.
Sure, thanks. It's an interesting question. There is good data that adrenal insufficiency is responsible for a proportion of the babies who suffer from post-ligation, or I guess post-transcatheter cardiac syndrome. However, and responsible for catecholamine-resistant hypotension. Identifying those babies preoperatively has proven elusive, and with the relatively smaller proportion of babies that run into trouble, prophylactic administration of hydrocortisone seems unnecessary. We are looking at that in a multi-center study, as Bonnie mentioned, with Iowa and Edmonton and Toronto. to see whether the role of hydrocortisone in which particular patients may play a role. I think it'd be suffice to say that babies who have developed post-catheter cardiac syndrome, that especially with systemic hypotension, those are the babies where almost all clinicians would administer hydrocortisone, given our knowledge of the pathophysiology and role of adrenal insufficiency, but probably not prophylactic for everybody.
That's interesting because in Memphis, during the procedure, they give a dose of calcium chloride. And when I speak to them about post-closure syndrome, they've never seen it. At least the person I spoke to said they've never seen it in their population. They've done several hundred implants.
Yeah, I guess we use, since the introduction of targeted milrinone prophylaxis, targeted milrinone treatment at sick kids, which was in probably 10 or 15 years ago in 2008, the incidence of post-ligation or post-device syndrome went from about 40% to less than 11%. And then our last count, at least amongst the ligation group, the incidence was about 6%. So milrinone, despite the there's no RCT evidence for the use of milrinone outside in neonates. There's good evidence that it prevents low cardiac output syndrome in the pediatric population. And pathophysiologically, it makes a lot of sense to use it in this type of scenario with instantaneous increases in LV afterload, as well as in parents who have known diastolic dysfunction. I guess using milrinone may obviate the need for hydrocortisone, and that prophylactic use, which our colleagues in Iowa have been practicing at their center, did not seem to reduce the incidence of post-device closure syndrome.
Great, thank you. The next question is twofold. Do you offer parents to choose between surgical ligation or catheter closure? And secondly, should other centers start to offer parents to choose between surgical ligation versus catheter closure, i.e. transfer to sick kids for their babies?
So I would say that given our experience, device closures are first choice. And if the duct is not suitable or the patient is deemed for whatever other clinical parameters is deemed not suitable, then we would revert to surgical ligation. But I think certainly given our success over the last couple of years, correct me if I'm wrong, Lee, but that is our preference now, is to move towards device closure. It is so well tolerated by our babies that we feel that probably is the best course of action if the child is deemed suitable.
We have reached out to London, Queens, Ottawa. I think this question is from Maher McMaster, to get more referrals. We are constantly in talks. We have got some referrals, but these babies, we have got them when they are 36, 37 weeks. We are trying to push the envelope by getting them to refer early, which might help in reducing their overall BPD rates or having these babies to recover from the respiratory standpoint quicker.
Thanks, Bonnie. I'll just add a little bit to that from the perinatal center side, that we have the discussion at our sites before we transfer babies that we discuss both procedures, and just like I think many clinicians, the nice part we discussed that the nice part about catheter-based closure is the avoidance of chylothorax, pneumothorax, vocal cord paresis, and those are things in the literature, at least, especially chylothorax and vocal cord paresis, are associated with really significant morbidity and sometimes mortality. So parents tend to mirror our enthusiasm, and whether that enthusiasm is misplaced or not, I think begs broader study, and at least larger observational studies, perhaps with historical cohorts or contemporary cohorts across centers, to really tease out whether device closure is actually as safer than ligation, which is our perception, but still more data to come.
Thank you. Since the studies reported no need for inotropes, but many were supported post-procedure in your cohort, do you think it's force of habit or lower threshold to support with inotropes in your center?
I'm glad someone asked this question. So we don't know in those observational studies, what was the in systematic reviews, it's difficult to have a truly homogeneous population in observational studies. So that's the fallacy of that systematic review. And secondly, at our centers, you're right. Maybe we are jumping the gun early with having the first echo without a true incidence of rising FiO2, low blood pressures, just on the basis of an echo to start milrinone. At times, I have seen that if the blood pressure shoots up quite instantaneously post-procedure, our medical team might be more proactive in starting milrinone. So there is more to that story. I don't think so. Our center has more sicker and they're more unlucky patients.
I think it's the echo that's done at 4 hours that often drives it.
Right. Yeah.
Because I certainly, so I check these echoes in the cases that I do, and then I quite often phone up to the ICU to say the LV function doesn't look so great, even though there's no clinical evidence of problems.
Yeah.
So I think we're treating an echo, albeit that some of them do look like they've got significant dysfunction. So I think the threshold has changed.
Yeah, and many babies do recover. I think there were 2 babies where the team did not elect to treat, and those babies recovered by the 24-hour echo. So teasing out which babies need or do not need, I think it would be a good idea for the group to come together and lay down some entry criteria for milrinone.
Great, thank you. Just a few more questions. Is it safe to say that you rarely attempt PDA device occlusion in the first month, given the higher complication rate you have noticed?
Since I've analyzed this data over the past 48 hours, I would, so we have not done any patient less than 25 days. I think our earliest patient was 27 days, in and around a month's time at SickKids.
But I would say that the referral does come in earlier. And so it's not because we're not willing to do it sooner, it's just because of all the other complications of extreme prematurity where, as Rajiv mentioned, the baby's ready, we have a date booked, and then the baby comes septic or develops neck. And so everything goes on hold until the baby recovers, and then we try again to transfer. But based on our protocol, it is any baby who's greater than 2 weeks of age and more than 750 grams.
Yeah. And I think one very practical point is, which we have noted in the perinatal center, some of these babies are stuck on HFO and they are not able to transition to conventional ventilation, even with the best of strategies. So I think at times it's the severity of lung disease, in addition to all the morbidities which Lynn mentioned, which holds them back in the perinatal centers.
You know, there are some centers which have done the procedure on a jet ventilator, which is a little bit easier than the high frequency. And there's some technical issues for that usage in the catheter laboratory, which is why we like to get them on conventional ventilation. But it can be done in a jet ventilator.
Thank you. Approximately 1,500 babies in Canada a year are less than 29 weeks gestation. Not all centers will have the expertise for transcatheter closure. Beyond this webinar, do you have any plans for remote education and support?
Now send all the patients to SickKids.
They
on
are
the jet plane.
Mary says, are you from Winnipeg? I think that's the message from Winnipeg. So
I guess the question would be, Lee, is whether or not there is interest amongst the interventional cardiology colleagues across Canada in terms of developing this skill, and you know, what would be the critical volume that would be required to develop competency.
Yeah, I can't answer the question in terms of volume. It's always a very operator dependent, technique dependent, you know, comfortable level issue. I know for that that we as an interventional program at SickKids would be more than happy to proctor, whether that's online or if there was a number of cases that were put together and able to travel. I think personally it's very difficult to want to fly to Edmonton to watch them do a case and then fly back to Toronto. I think that's very impractical, but it's not impractical to have interventionists who are comfortable in closing ducts that are in the 2.5, 3, 4 kilogram range, and then be able to do the procedure under, proctorship online. And there have been a couple of procedures where during the pandemic that proctors have actually done the proctoring over Zoom and worked the procedure with the operator, by a teleconference kind of a modality.
Thank you. In those premature infants with BPD, late pulmonary hypertension, and a large PDA, would you recommend PDA closure via device?
So I think that's a case-by-case decision. It requires, so if you're talking late on, often when the baby's home or in, not in the NICU, but maybe perhaps a high dependency. So many months later, it really depends. And you need to check the resistance, in the ones that are really sick, you need to evaluate the resistance and do an evaluation prior to doing it. So you can set things up for a catheterization with the decision to be made actually within the procedure.
Lastly, have you considered doing the procedure in the NICU and not in the cath lab?
No. I know it's Cedars-Sinai. Evan Zahn has developed a portable fluoroscopic unit that he can bring into the neonatal unit, and he's done the procedures in the neonatal unit. I don't know how safe that is. You have to be very comfortable in doing those things. I know it's also been done with just echo in the neonatal unit in England with some success, some very good success. But I think we're still very early on in our appreciation of device implantation, which is purely echo guided, before we would undertake that at sick kids.
There is also just a practical issue within our NICU is that we have a space constraint, that we are in a multi-bed unit. We don't have single patient rooms, and so there really isn't the space to be, we would have to empty out that room and move other patients out in order to do this procedure. So if we are able to, and we have been able to safely transfer these babies to the cath lab, that is ideal.
So it's not inconceivable that could happen. I think we're a long way from it. It sounds attractive in principle, but I think my preference would be that that's quite some distance from now, like we're talking years, maybe like another 50 to 100 cases from now, where you can select the long ducts that are not too big, and you're confident with your echocardiography that you know exactly what the duct is. But I think for us, it's too early, and I'm not sure there's a huge benefit to doing it.
Just yet.
Just yet.
Yeah.
But maybe with our new campus in 10 to 15 years.
No, I think with another 50 to 100 cases, you could think about it.
Okay, I'll start to plan that.
Okay. Yet another year from now. Well, I guess it's towards the end. I want to thank all of the speakers. They were terrific. And it's recorded. You can play this over and over again indefinitely if you'd like. I'll send everybody a copy. I think we might put it on YouTube so that other people can take advantage of the discussions and the presentations. So I want to thank the speakers. It was terrific, and I want to thank the participants who have stayed until 8 o'clock at night listening to the program, and I hope you enjoyed it as much as we did in putting it together. And I thank you very much.
Thank you.